Welcome back to Core Anesthesia. Whether you are a student prepping for tests and boards or a CRNA here to earn CEUs, we are glad you've joined us. For more about us, make sure to check us out on Instagram at Core Anesthesia and online at coreanesthesia.com.
Welcome back to Core Anesthesia. I'm Cole, here with Tanner, and today we're going to move into the cardiovascular realm, and we're going to talk about some various complications that we can see both within the heart itself and then also the peripheral vasculature. And so some of the things we're going to be going through today are peripheral vascular diseases, including carotid artery stenosis and then abdominal aortic aneurysms. And we're going to talk through the different pathophysiology of those, but then also the surgical procedure itself and how our anesthetic is going to be altered because of that. And then we're going to jump into congestive heart failure, cardiovascular collapse, cardiac tamponade, and then hypertension. So we got a nice full and packed agenda here to go through. And just a disclaimer before we start, to do this all within an hour episode, we're not going to be able to do everything in the complete detail involving everything that goes into each of those different abnormalities. But we want to hit the high points and what we should know from an anesthetic standpoint and what we should be prepared to have to alter in order to best provide care for these patients. So Tanner, let's just start us off here with peripheral vascular disease, go over a broad overview of what that is, and then we'll jump into two of the main ones under that category, which would be carotid artery stenosis and then the aortic aneurysm.
Right. So what's happening when we're dealing with peripheral vascular disease or PVD? The most common cause of this is going to be from atherosclerosis. Typically, this is cholesterol-based plaques that are going to be in the blood vessels that will continue to build up. Eventually, you're going to have more and more of this plaque build up to where you have an obstruction. You're going to have limited blood flow that's able to go past that obstruction, and then you're going to have, not enough oxygen going to those tissues that are past that obstructive point. You can also have risk for these plaques breaking off and causing embolisms further down the line. That's something that we're very concerned about as well. Smoking and hypertension are going to be really high risk factors. We're here, diabetes as well. You can see this with obesity. Obviously, family history is going to be a determinant factor as well. So those are some of the comorbidities that you would associate here with peripheral vascular disease. When you're looking, at a patient and you're doing your assessment, some things that can clue you into this being an underlying condition, aside from obviously going through their chart and understanding their history, is looking at, what does their skin look like? You can see some skin ulceration. This is very common in the lower extremities. You'll see this with patients who have advanced peripheral vascular disease, where you're having, difficulty perfusing those lower tissues. And so you'll see that skin ulceration be very apparent many times on these patients. When we're looking at treating these patients, there's several different things that you can do. Typically, angioplasty, you can do an endarterectomy, thrombectomy. Stenting is also another thing that you could do here. And also bypass, we'll talk about that here in a little bit. But basically, the root cause of the problem is that we have an occlusion that blood flow is not able to go past, and now we're having the decreased amount of oxygen going to those tissues down the line. So do we need to clear out the plaque? Do we need to, create a stent that prevents that space from getting any smaller? Do we need to create a complete bypass? These are some of the options that we can do to try to, restore the blood flow there to the tissues. When we're looking at these patients and we're trying to optimize them for surgery, some things that we should consider is a prophylactic beta blocker and definitely statin therapy for these patients as well. So beta blockers, we'd like to have those on, and titrated, have a baseline. That's not something that you're going to be starting the day of surgery. That's something that's going to be started before surgery. And you're going to want to get them to a place where their heart rate is typically 50 to 60 beats a minute is going to be kind of the sweet spot where you have that beta blocker therapy. The reason for this is associated with less cardiac ischemia and overall decreased mortality. Statins, on the other hand, are cardioprotective. They're going to reduce the vascular inflammation. They'll also stabilize the atherosclerotic plaques as well, which again, we talked about, the risk of embolisms there at the beginning. So this is a key point here. We're talking about the statins. As I mentioned with the beta blockers, with statins as well, you're going to want to start those prior to surgery. Really, about 30 days prior to the procedure is where you're going to want to start these beta blockers and these statins before. When we're talking about how we want to address these patients from an anesthetic standpoint, some of the things that we need to keep in mind are maintaining the hemodynamic control to ensure that you have oxygen delivery to those vital organs. You also want to try to minimize myocardial oxygen consumption. So there's not really one strategy that has been found to be more successful than another. Really, it's keeping those high arching goals in mind and then trying to find a plan specifically for each patient to maximize those goals. Two key notes I wanted to mention here when we're talking about doing surgery for patients that have AAA or they need a stent or something like that. It has been shown that the combination of an epidural with your general anesthesia showed a decrease in the rate of myocardial infarctions, decreased strokes, decreased respiratory failures as well. So that is something to keep in mind when we're doing these large aortic surgeries, to consider they're using an epidural as well to your general anesthetic. Also, remember that inhalational and intravenous anesthetics will decrease the rate of oxygen demand and will offer some protection there with the neurologic and cardiac tissue. So remember that part of what we're doing is going to be, in essence, helpful just because it's going to be decreasing that oxygen demand of those essential tissues. When we're talking about these patients in the postoperative setting, our goal is to control their pain level. Pain is, as you know, associated with sympathetic nervous system stimulation. That's going to increase inflammatory mediators that can lead to blood flow alterations. And so our goal here is to minimize, the amount of ramp up that we have here and to control that pain. Narcotics will provide good pain relief. They also are pretty cardiac protective, or I should say cardiac stable. You're not going to have major cardiac depressive effects there. Precedex is going to be beneficial here, both from an analgesic profile, but also it has some patholytic effects as well, which will protect there from getting that sympathetic stimulation as well. There's an increased risk for venous thromboembolisms in the postoperative period. Often we will give these patients low molecular weight heparin to bridge them until they can restart their anticoagulation that they were on preoperatively. And so this is something to just make sure that we're paying attention to when we're handing off, giving a report. There's a risk there as these patients are typically off of their anticoagulants, definitely for an elective procedure, but just typically when you have a procedure that you're going to be doing, you're going to have them paused on their anticoagulation. And so we want to make sure that we do not miss this really crucial point here in the postoperative period where they could have an increased risk for those thromboembolisms.
So next, let's jump into carotid artery stenosis. And this is a narrowing of one or both of the carotid arteries. And carotid artery stenosis is one of the known risk factors for stroke due to the potential for a decreased blood flow up to the brain, as the internal carotid arteries and the vertebral arteries are the two main arteries that supply blood to the brain. So roughly 87% of strokes are going to be ischemic in nature rather than hemorrhagic. So meaning that there's 87% of the strokes are going to be as a result from some type of blockage of that blood flow to the different tissues in the brain. Now, the stenosis here most often occurs where the carotid artery bifurcates, where it splits into the internal and the external carotid arteries. And for more treatment specifically on the ischemic stroke pathway, you can go to our episode that we did on the neurologic complications, and that'll include stroke identification and treatment from there. We're not going to go into that today, but specifically we're going to talk about, because carotid artery stenosis increases the risk of having that stroke from the ischemic nature, how are we going to treat that from a surgical standpoint? And then that's where we become involved. How do we, from an anesthetic standpoint, handle that? So surgical treatment of the symptomatic carotid artery stenosis is going to involve the removal of that plaque in the artery. It's called a carotid endarterectomy, and it reduces then the risk of having stroke. And so preoperative evaluations on these patients show that the association between the carotid artery stenosis and coronary artery disease is elevated along with hypertension as well. So just think if you're doing a carotid endarterectomy on a patient with carotid artery stenosis, the patients are most likely going to have coronary artery disease and hypertension. So take a look at that with your preoperative assessment. So you can plan appropriately for patients that would fall under those categories as well. So they're probably going to be at an increased risk for having an intraoperative myocardial infarction. So it's imperative then to determine their preoperative baseline systemic blood pressure in order to better provide oxygenation to the brain during the cross clamping of the carotid artery. Because basically what will happen is the surgeon, when they open up into the neck and they find the spot that they want to remove the plaque from the carotid artery, they will clamp below and above that section on the carotid, and they'll stop flow going through that section. So they can open up the vessel, remove that plaque, close the vessel, and then restore blood flow again. And so it's very important that we know what their baseline systemic blood pressure is, because we got to figure out how to continue to oxygenate tissues distal to where they clamp at. So in the brain in this case. So very important tissue that we're going to be oxygenating. We don't want to have ischemia to those tissues during this procedure. And I'm going to get into that here in a second. But the anesthesia itself for carotid endarterectomy can be either regional or general anesthesia. And both cases are going to revolve around very careful control of the hemodynamics. And the goal is then to have the patient awake enough at the end of the procedure to do a neurologic exam. We want to make sure that there is not any neurologic deficits from a lack of blood flow to the tissues during this case. So if you do a regional anesthetic, this is usually going to involve a cervical plexus block that then enables the patient to remain awake during the procedure, and they can provide real-time throughout the case neurologic assessments. And some surgeons very much favor to do this route so they can constantly be assessing the patient each time. That is basically the gold standard in terms of being able to tell if you're perfusing the brain well enough, if the patient is awake the whole time and you can assess them. The other side of things is you can do a general anesthetic. And in this case, again, you want the patient to be able to wake up enough at the end of the procedure to do a neurologic exam. So keep that in mind. This is not going to be something where potentially you're pulling the endotracheal tube deep and then you're having to wait for them to wake up. This is something where you're going to have to be planning your anesthetics so that they're not deep at the end of the procedure. So for both cases, though, you're going to want to make sure, depending on if you're doing a general or a regional, doesn't matter, their blood pressure management is paramount. So during this procedure, again, like I said, the surgeon is going to cross clamp the carotid artery in order to block the flow of blood long enough for the surgical removal of that plaque. And so during the cross clamp, we want to ensure that the brain's still getting perfused, so getting adequate blood supply. And we often will do this with the use of a vasopressor. Phenylephrine is the main one that we see, that is used to increase the blood pressure to provide blood through the collateral circulation. So again, the other carotid artery is going to be open, and then also the vertebral arteries are going to be supplying blood to the brain when we're clamping one of the carotid arteries. So we want to make sure the pressure is high enough in those vessels so that collateral circulation gets enough compensation to get blood flow to the brain while we're blocking off one of the carotid arteries. Now, additionally, we should be mindful of the fact that when the surgeon's working around the carotid sinus, any surgical manipulation of that can significantly alter the heart rate. So often we will have atropine, glycopyrrolate ready to go in the instance that we do have a significant drop in the patient's heart rate and we need to pharmacologically increase that back up. But now, like I said, as we're doing this throughout the case, our main goal here is to provide enough oxygenation to the cerebral tissues. We do not want cerebral ischemia. And so typically surgeons will have different preferences on the way they want to monitor this, and they often will communicate with the anesthesia team to determine the best route for each patient. But monitoring for cerebral ischemia can be done a couple of different ways. So there can be neuromonitoring, which can be done through standard EEG or SEP monitoring. And again, if you have a neuromonitoring tech in the room with you, you have to discuss with them in terms of what they're okay with you doing from an anesthetic side of things, not to alter their readings. And then additionally, we can also use cerebral oximetry to make sure that we're perfusing the brain. And some surgeons like to use stump pressures as well. And stump pressures basically measure the pressure on the distal side of the cross clamp. So this would be pretty much measuring what is coming from the collateral circulation back on the back part of that clamp to ensure that there's a high enough pressure there that they're getting enough blood flow. And regardless of how you're monitoring this, the reason we're doing this cerebral monitoring for cerebral ischemia is to determine if the patient would benefit from a carotid artery shunt when we're on cross clamp. And so if any of these show that there is cerebral ischemia, then the surgeon will do a shunt around the cross clamp in order to provide oxygenation and blood flow through that vessel while they can still operate. Now, like I said, patients are going to be woken up. If they're under general anesthesia, they'll be woke up at the end. If they're regional anesthetic, they'll already be awake. And they'll be assessed for any neurological deficit at the end of this as well. And so post-operatively, both hypertension and hypotension is commonly seen based on what kind of altered activity there is with the carotid sinus. So if that plaque was very close to the carotid sinus and there was manipulation with that, you can have different patients react differently. And depending on that blood pressure alteration, you're going to be using either short-acting vasodilators such as Clevaprex, long-acting vasodilators such as hydralazine, or if it's a hypotension response, then you're going to be using phenylephrine, for example. So depending on how they respond will depend on what you use in recovery. So surgical treatment, before we move on to aneurysms, there is another way that you can surgically treat this, and it's through an endovascular treatment. And I'm not going to go into the whole surgical procedure of that, but the risk factors of doing open versus this endovascular treatment is that in the endovascular treatment version, there's a lower risk of a MI during the procedure, but there is a higher risk of a stroke via the microembolization from those plaques during the procedure. So different surgeons have different preferences. And again, it depends on the patient population and it's all on an individual basis. But that is I feel like a growing number of cases are going the more endovascular route as more and more technology is coming out that minimizes the risk of those microembolizations during the endovascular procedures, which then makes it more of a favorable route to do than the carotid endarterectomy.
All right. Hopefully you're still hanging with us and are enjoying the different complications that we need to talk about today. The next one we want to talk about is a AAA, abdominal aortic aneurysm. This is a dilation in the lining of the artery. This will appear ballooned in, a specific region wherever the actual aneurysm is. And typically the patients that have this will present with some abdominal pain. Could be chest pain as well. And, this is something that you can look at the presenting factors, but ultimately you're going to need to get imaging to identify that the AAA is occurring and also get measurements. And typically we don't have any repair if the aneurysm is less than 5.5 centimeters. As that continues to grow or if the patient is symptomatic, there's more risk there for rupture, and that's where intervention would be necessary. Risk factors for AAAs are things like smoking, family history, coronary artery disease. If you have high cholesterol, you're probably seeing a trend here today with the risk factors in all of these looking very similar, and there's a reason for that. But, very similar to what we've talked about already, and no different here with the AAA. Often you'll see these patients will have hypertension, and again, atherosclerosis. Makes sense that you have damaged or weakened vasculature, and then the hypertension is causing this increased pressure, which will cause that ballooning or the aneurysm to occur. Like Cole mentioned when talking about the carotids, there are two main ways that we can approach the repair here: endovascular, and you can also do open. Endovascular for this repair will be accessed through the femoral artery there to the abdominal aorta. And then the endovascular stent graft will be placed over the dilated section there of the aorta. Some complications that you can see with this would be endoleaks. You can see some injury to the vessel walls while you're placing the graft. You can have an inadequate sealing of the graft to the wall, and so potentially you could get graft migration. I actually took care of a patient that came in with their graft having migrated and was experiencing all types of issues. And it was a complicated procedure to locate the graft and to remedy that situation. So that's a risk factor here when placing it through the endovascular route. Eventually, after these endografts are placed, the aneurysm will thrombose and will decrease in diameter and therefore be a resolution to the problem here. During the actual repair, it's important to pay attention to a couple of things. While we're not doing aortic cross clamping like we would in an open procedure, there's still the possibility for spinal cord ischemia because of some intercostal arteries that could potentially be blocked. And so it's important there to have really, really good pre-procedure baselines, post-procedure baselines, and also just that we're monitoring the patient throughout the anesthetic. We should also be monitoring the urine output very closely, as we could also have limited blood flow there to the kidneys, depending on where that graft is placed. Like the rest of these procedures that we're talking about, we're going to be very closely monitoring and manipulating the blood pressure. You'll want a art line or some type of invasive blood pressure for this case. You're going to want to have several large bore IVs. If there's a potential here that you need to convert to open or you get into bleeding, you're going to want to have adequate IV access. You're going to be monitoring ACTs, giving heparin, and many times reversing with protamine at the end of this case. So that's something that we're going to be also closely managing throughout this procedure. If we're doing an open repair, this is going to be done through a midline abdominal incision. This is a little more touchy when it comes to managing the patient's blood pressure, as we're going to be clamping the aorta. Many times, this is going to be a kind of a dance with the surgeon as you are monitoring and managing their blood pressure. And as you are allowing them to come off of clamp, you're also going to be managing their blood pressure there as well, many times with some pretty drastic decrease in the blood pressure as you're releasing all of that tissue that wasn't being perfused throughout the case. And then you're also dealing with a much larger systemic vascular picture compared to when you were clamped there during the procedure. Many times you can do this with general anesthesia, then you're also seeing additions of epidurals very frequently with this procedure for postoperative pain management. Again, you're going to want an A-line with this case as well, and you're going to want to also have your access large bore IVs for this case. With your A-line, it's going to be important to be managing and monitoring their blood pressure. It's also going to be very helpful to look at their fluid therapy and to be able to have guidelines for managing their fluid status as they are clamped and then unclamped as well. You're going to want to limit hypertension and a tachycardic picture with these patients. It's not our goal, not our job to be challenging the integrity of the aneurysm. And so you want to make sure that you are doing everything that we can to minimize the risk there for acute hypertension. You can give Esmolol during induction. You can also, run a higher narcotic technique. If you're waking them up at the end, you're going to want to also pay attention to trying to get them very, very comfortable so that you're not having them buck and, really putting stress there on the repaired aneurysm. With these open AAAs, you're going to want to have blood tubing primed and ready to go with pressure bags as well. This is something that we are not taking any chances. When this goes badly, it goes badly very quickly. And so we need to have all of our remedy solutions available and set up ready to go. Like I said, large bore IVs, central line is going away as the standard, but is also still pretty commonly performed for these. You're going to want to maintain normothermia, so you want to have fluid warmers on your fluids as well. Another thing that you need to have in the room is mannitol. Many times we're going to be giving 0.5 to 1 gram per kilogram just for renal protection there prior to clamping the aorta. Let's talk quickly. I already touched on this just briefly about the aortic cross clamping, how that's going to look as we're clamping, as we're unclamping, and how we're going to manage these patients from a hemodynamic standpoint. So once the aorta is clamped, distal blood flow is going to be relying on collateral circulation through the spinal cord and also through the kidneys, just depending on where the location of the clamp is. In this situation, we want an increased blood pressure to assist in getting blood through to the collateral circulation. If we're clamped for more than 30 minutes, we have increased risk for renal failure. And also your anterior spinal cord is at risk for ischemia, which can cause paraplegia as well. The reason for this is we only have one anterior spinal artery, and that comes from the vertebral arteries and the artery of Adamowicz, and that can be blocked by the cross clamp. And so it's, again, very important that we have really clear before and after baselines of the patient's status and that we're paying attention to those risks there. You may need to employ some techniques for spinal cord protection, such as CSF drainage or proximal hypertension, hypothermia. You can also give some steroids, which would all be helpful in spinal cord protection. Hemodynamically, when we are placing the cross clamp, you have a picture here that is grossly hypertensive above the cross clamp. Think about the patient's blood pressure, and now we are pushing that same circulatory volume just through the area mainly that is above the cross clamp. And then now we have gross hypotension below the cross clamp. You will have increased catecholamine release, which causes vasoconstriction above and below the clamp. The heart has a increased afterload to pump against, which is going to increase your myocardial oxygen demand. Often we already mentioned that one of the biggest risk factors here for AAAs is atherosclerosis, and that doesn't just stay in one area of the body. That can be throughout the vasculature. And so if you have these patients that have potentials for an MI, this is something else that we're considering as we're going to be increasing the myocardial oxygen demand here as well. You're going to see increased blood return to the heart. So you have increased preload. I mentioned we have increased afterload. Now we have increased preload as well. And then you're going to see decreased blood flow distal to the clamp. So you'll see an ischemic environment. This will switch to anaerobic metabolism, which will create more lactic acid, more prostaglandins, nitric oxide. And these are all going to play into what the patient picture looks like as we unclamp, and all of those now are mixing systemically. As we are releasing the aortic cross clamp, now we have a decrease in the SVR. So initially when we cross clamped, we were minimizing or decreasing the amount of circulatory space that we were dealing with. Now we've unclamped. Now we're bringing back into circulation the whole lower half of the body. So now your SVR is decreasing, venous return will decrease. And this is also caused by what we call reactive hyperemia. And this is where the anaerobic metabolites are washing out throughout the body. And so you'll see a hypotensive picture here. Many times this can be so severe that you will have to ask the surgeon to reclamp or to partially reclamp just to minimize or kind of step by step make your way into this new hemodynamic picture. If it's too drastic for the patient to tolerate, then this is, like I said earlier, kind of a dance that you'll do with the surgeon to do this safely. We're going to prepare for this by giving lots of fluids prior to unclamping. And you can also do things like decreasing the patient's anesthetic depth if that's appropriate. You'll want to start pressors. Typically, we start phenylephrine even while the pressure is adequate because this profound hypotension is about to happen. One other thing that we can do here is that because of the anaerobic metabolism, you have a metabolic acidotic picture that will develop as all of those metabolites are washed into the systemic vasculature. And so we can give sodium bicarb and increase your minute ventilation ahead while you're starting this neo-drip, while you're giving the fluids. And this is all, again, to try to transition the patient from this clamped picture to unclamped in an effective manner.
So this is going to wrap us up for part 1 of our cardiovascular complications episodes. So far, we've went through the peripheral vascular disease process, carotid artery stenosis, and then abdominal aortic aneurysms. Stay tuned with us for the next time in part 2 as we cover heart failure, cardiovascular collapse, cardiac tamponade, and hypertension.